Hello, and thank you for joining us for Scope of Practice in the DMV. This is part of MSDC's WOW Washington Healthcare Series, and we're pleased to provide to you through this program weekly content that helps physicians with their personal and professional needs. We're hosting this webinar tonight because DC has long faced scope expansion challenges from allied health providers. However, during the pandemic, we saw that the emergency environment and worker shortages opened the door to more permanent scope expansion for allied health practitioners, ironically, putting patients at greater long-term risk. States across the country are facing scope of practice challenges, and that wave of challenges has hit our nation's capital here in DC. We're pleased to have our neighbors down in Virginia who have also seen scope expansion challenges to discuss this important topic with us tonight. And with that, I'm going to, we have Scott Castro, Health Policy Director from the Medical Society of Virginia, to speak to us about what they're seeing in Virginia. And our host is Dr. Klint Peebles, who is the MSDC Advocacy Committee Chair. Thank you very much for joining us.
Well, thank you so much, Pia. I appreciate your help putting all of this together. And thank you so much, Scott, for being here and for being a part of this session for our members and to help us out here in the district. So we always appreciate collaborating with our neighbors. So thank you so much. As Pia mentioned, I'm Klint Peebles, chair of the Medical Society of the District of Columbia Advocacy Committee. And first, I just want to thank everyone for watching and for being here. And again, thank you to Scott, who will be enlightening us as to the experience on the ground in Virginia. As Pia mentioned, scope has been a top priority issue for the House of Medicine for years now, and the urgency is only building, I think, over time. And that's been amplified by the challenges of the COVID pandemic and addressing workforce concerns to meet the needs of our patients. And like most regulatory issues, scope of practice has become a complicated patchwork across the country, and our DMV area is no exception. So to start the conversation, I did want to provide some background before we dive in and get Scott's take on things on what exactly we mean by scope and why this is so critically important. And I recognize that many are already aware of a lot of this and the context that we're looking at, but just to make sure we're all on the same page, I just want to be completely clear first that we believe in the concept of team-based care, and we recognize the value of a diverse array of talents, skill sets, and voices on that team. However, we are aligned with the values and ethics of the American Medical Association, and that physicians should be at the helm of that team, and that access to physician-led care should be fundamentally protected. And this is really important, not just for arbitrary reasons, but because of an evidence-based and data-driven reality on the ground, which we're going to be talking about. And so first, just for a little bit of additional background, physicians are trained to lead with the highest level of education and up to 20 times the clinical training as other allied health professions, depending on the skill set you're looking at. And as an example, if we look compared to nurse practitioners, physicians have 4 years of education compared to 2 to 3 years, with nurse practitioners, depending on the training, a 3 to 7 year residency, depending on specialty and focus, compared to no residency with nurse practitioners, and 10,000 to 16,000 hours of direct hands-on clinical training with physicians, compared to only 500 to 720 hours with nurse practitioners. And all physicians do get critical hands-on instruction, but 60% of nurse practitioner training programs in 2019 were mostly or completely online. And second, we know that scope expansion increases costs. And as a few examples of that, research has shown that non-physicians needed twice the number of biopsies as physicians to screen for skin cancer, which is particularly relevant to me as a dermatologist. Patients were 15% more likely to receive an antibiotic from a non-physician. 6.3% of nurse practitioners prescribed opioids to over half of their patients, compared to 1.3% of physicians. And X-ray ordering had increased by almost 450% among non-physicians. And third, we also know what our patients have to say, and that our patients do prefer physician-led care. More than 90% of patients in a survey say that a physician's education and training are vital for optimal care. 75% would wait longer and pay more to be treated by a physician. And 95% say it's important for a physician to be involved in their diagnosis and treatment. And fourth, I think there is a pervasive myth out there, which has sadly impacted public thinking as well as lawmakers, that allowing non-physicians to practice without physician involvement will somehow increase access to care in rural and underserved areas. And the reality is that states with laws allowing non-physicians to practice without physician supervision or collaboration has not guaranteed increased access in rural and underserved areas. So what does this mean? Well, it means that healthcare teams working together with physicians in the lead is critical to having the best and safest outcomes for patients. And this fight is playing out across the country. Just last year, the American Academy of Physician Assistants voted to change their professional title from assistant to physician associate at their House of Delegates meeting by a vote of 198 to 68, which per their website followed several hours of deliberation by House of Delegates members and several years of study by an international marketing and communications firm. And this provoked a resolution at the American Medical Association House of Delegates meeting shortly thereafter, co-sponsored by the Medical Society of the District of Columbia, which directly opposed this and advocated that the standalone title of physician should be used only to refer to doctors of allopathic and osteopathic medicine and not be used in ways that have the potential to mislead patients about the level of training and the credentials of non-physician healthcare workers. And that resolution did receive unanimous support and is now policy of the AMA. And because of the work of organized medicine, we've also seen some efforts in several scope bills throughout the country, including one in South Dakota that would have allowed physician assistants, for example, to practice without any physician involvement, and a Mississippi bill that would have allowed APRNs to practice without any physician involvement and even allow some nurse practitioners to serve directly as their consulting provider. And because of the efforts of organized medicine, including the AMA and direct efforts of MSDC, many of those measures have been dismissed for now. But in the district, we may not be facing any of these direct, tangible challenges just yet, but this may soon change. DC Health has said they want to rewrite the Health Occupations Revision Act, or what's known as the HORA, which regulates medical licensing and scope of practice in the district. And DC Health has asked all medical boards to weigh in on changes they would like to see. So it's unclear what may be coming. MSDC has made it clear to the Board of Medicine and otherwise that it does oppose any action to rename physician assistants to associates, which is just one example of the work MSDC is doing. And also of note along with that is that athletic trainers in the district have asked the council and Board of Medicine for expanded treatment abilities. So this does span the full spectrum of the allied professions, who again are our pivotal colleagues in addressing the needs of our patients. But we believe as a society and as an organized medicine that a physician-led team is imperative. So we'll soon see instances in which it will be necessary that we as a physician community staunchly advocate against dangerous scope expansion efforts. And to that end, we are privileged to have our colleagues in Virginia talk about their experiences. And I'm happy to turn it over to Scott for a perspective about how we may see our intersecting efforts within our jurisdictions and how we can learn from each other. So thank you, Scott.
Yeah, thank you so much, Dr. Peebles. First of all, let me say if you happen to hear any background noise on my end, I do have a 6-month-old. He's being particularly boisterous tonight. So shout out to the pediatricians out there. You've been number one in my heart for these past 6 months, so much appreciated. All that is to say, just to give you a bit of context as to where we are at in Virginia right now in terms of our legislative timeline. Today is what's known as crossover in Virginia. Just providing a bit of context in the background that I'm giving you. Today is the last day of bills that originate in our House to make it through the House in order to move over to the Senate. And bills that originate in the Senate have to make it out of the Senate by the end of the day in order to move on to the House. A lot of bills' fates are determined today, just because, just the way that the subcommittee and committee structure works, it's all pretty back-ended. So yesterday, I believe the legislators were on the floor for about 12 hours, and they are still on the floor, I believe, as I'm speaking to you. So some long days ahead. But as far as as far as scope is concerned, I wanted to highlight a couple of specific issues for you all. And again, just to reiterate the value that our members provide in allied health professionals. They work with professionals to kind of across the spectrum, and we believe in the kind of the physician-led patient care team model as the AMA trumpets as well. So one of the biggest scope issues that Virginia physicians have been facing over these last couple of years has been coming from nurse practitioners. And in Virginia, in 2018, nurse practitioners were able to. There was a bill passed allowing nurse practitioners with 5 years of clinical experience to be able to practice autonomously, during, as Dr. Peebles kind of referred to, during the pandemic, our Governor Northam actually issued an emergency order that would allow nurse practitioners with only 2 years of autonomous practice to practice, 2 years of clinical experience to practice autonomously during the emergency protocol. And there was a bill last year that essentially extended that sunset for another year to expire on July 1st of this year. And so for the last 2 years, nurse practitioners with only 2 years of clinical experience have been able to become licensed and practice autonomously in the Commonwealth of Virginia. The piece of this that's particularly interesting is when that bill was passed in 2018 to allow nurse practitioners with 5 years of clinical experience to practice autonomously. It also asked our Department of Health Professions to do a study to see if nurse practitioners with 5 years of experience, providing the same level of care that physicians were, and really to kind of see if they were actually expanding access, right? Were they actually moving into the rural parts of Virginia where, that had, healthcare provider shortage areas? And that study was actually released November of last year. And it was essentially what it said was that, and first of all, it only looked at nurse practitioners that had 5 years of experience that were practicing autonomously. It did not include any of those nurse practitioners that had been practicing with only 2 years under the emergency order. So this is strictly that 5-year cohort. And what it found is that the vast majority of them that went to practice autonomously essentially stayed in the areas where they were practicing before, which already have very high, volumes of health professionals. In Virginia, we're talking about Charlottesville, where UVA is. We're talking about Northern Virginia, where Inova is. We're talking about the Norfolk Eastern Shore area, where there's large military bases and a lot of healthcare providers, and here in Richmond, where we have VCU. What we also saw was that there were 29 of Virginia's 95 counties that didn't have a single autonomously practicing nurse practitioner. And so what we essentially saw was that case of expanding access did not bear fruit. Nonetheless, the sponsor of that, of a few nurse practitioner scope bills has come back to the General Assembly this year to ask in one of her bills to make that 2-year requirement permanent. And so it's been a little bit difficult because we only have data looking at that 5-year cohort, and wanting to make a permanent change without really having looked at the effects of those nurse practitioners who have been practicing autonomously under the emergency statute. That's just one of the 3 bills that have been introduced by this particular patron who is a nurse practitioner herself. One who's been practicing for 30 years, very well seasoned, been in the healthcare landscape for a long time. And, frankly, under our previous, 5-year requirement would have, obviously is a very well qualified provider. She has, this legislator has introduced, again, that bill to make that reduction of permanent years of experience from 5 years to 2 years permanent. She also, there's another bill that she introduced that would allow nurse practitioners to be the heads of patient care teams, and also removed a requirement for nurse practitioners practicing autonomously to carry medical malpractice and liability insurance. That was kind of part of the 2018 bill with nurse practitioners who were able to practice after 5 years of clinical experience. One of the requirements was that they had to have medical malpractice liability insurance. This bill essentially removes that piece. I'm happy to report that as of now, that bill has essentially just been reduced to that med mal piece. So the piece about nurse practitioners leading patient care teams has been taken out of that bill, and it is moving forward with just that med mal requirement, which frankly, in Virginia, physicians are not technically required to carry medical malpractice liability insurance. So as we all know, if you want to be credentialed with a hospital or with a healthcare plan, they require you to have it. And so, as far as the medical malpractice piece, we didn't essentially really have a dog in that fight to require nurse practitioners to carry that additional coverage. There was a third bill that the same patron introduced, again, still talking about nurse practitioners, that would essentially increase the postgraduate requirement for physicians to become licensed in Virginia from the 12-month requirement as it exists now to 36 months. So this is kind of the other side of the coin from this patron's perspective in saying, essentially, if nurse practitioners have to have so many years to practice autonomously, why do physicians only have to have 12 months of postgraduate experience? And we were actually able to align all of the deans of the medical colleges and point out several reasons why it exists the way it is. One of them being that, as far as moonlighting is concerned, having physicians in residency being able to moonlight. Also, a lot of areas of Virginia that have been ravaged by the opioid crisis. These residents with 1 year of postgraduate experience are practicing in a lot of substance abuse clinics, being able to prescribe Suboxone and things of that nature. So providing a lot of public good. There's also military implications too, and that getting a little bit into the weeds there, but the way that obviously Virginia having a large military presence and physicians that are licensed or in Virginia that essentially ship overseas and being able to practice while they're on a ship. A lot of those things kind of came into play. That bill was defeated, and so that is kind of off the board as it were. The bill that remains is the bill that to permanently reduce those years of clinical experience from 5 years to 2. That bill will now head to the Senate. It did pass our House, and so obviously, we continue to advocate for our senators to oppose that bill, and we are kind of aligning our strategy as far as that's concerned now. Another scope issue that we've been facing in Virginia this year has to do with this new title that we've seen in the healthcare landscape of an associate physician. There are some states, I believe Missouri being the first of them, to kind of provide this new licensure pathway for somebody who graduated from medical school but was not placed into residency to essentially be able to practice medicine. The patron of the bill here in Virginia was looking for these folks essentially to come out of medical school. If they did not place into residency, they could apply to this licensure path, which essentially gave them full prescriptive authority, did not have any restrictions as to where they could practice in Virginia, and was kind of very open-ended, and even less restrictive than some of the barriers that Missouri places on their associate physicians. For example, in Missouri, they have to, in order to be licensed as an associate physician, they have to practice in one of those underserved areas or physician shortage or healthcare professional shortage areas. No such restriction was on this bill in Virginia. That has also been, that bill has been defeated. Our Department of Health Professions has promised to kind of re-examine this licensure path, though I will say that the same department examined this licensure path back in 2014 and recommended that Virginia not move forward with it. So, and then additionally, there was a very high-profile bill this year regarding optometrists and laser surgery. Not talking about LASIK here. We're talking about three 3 specific laser surgeries, and me not having a clinical background, I unfortunately cannot name them for you. I'm still myself learning how to spell ophthalmologist, but that's just my own self-growth. That's me working on that. But yeah, unfortunately, that bill that would allow optometrists to practice 3 specific laser eye surgeries. We've seen 7 states in the country implement similar measures. And the optometrist lobby came in pretty strong on this one. This is definitely one I would keep an eye on because it had a lot of momentum in the Virginia legislature. And though we were able to add on some additional reporting requirements, including mandatory reporting of adverse outcomes, to kind of, because a lot of legislators, frankly said, if this results in, a lot of problems, we'll wind this back. And so, it included some mandatory adverse outcomes reporting to be able to kind of keep an eye on this the years to come. But essentially, the optometrist came to the table and said, this has been in 7 states. We haven't seen a single med mal case about it. And that was frankly enough to convince a lot of legislators. So that's another one to keep an eye on regionally. And then finally, and this is also born out of the pandemic and kind of what was allowed under emergency protocols, and this was regarding pharmacist scope of practice. There's a bill here in Virginia that would essentially allow pharmacists to continue providing vaccines to children between the ages of 3 and 18, would allow them to test and treat for strep, UTI, and flu, would allow pharmacy techs under the direct supervision of a pharmacist to administer certain vaccines. And yeah, essentially a lot of the things that pharmacists were allowed to do under the federal emergency order, making those changes permanent here in Virginia. That bill is still alive, unfortunately, though we have again attached a bunch of amendments to that to have state protocols from the Board of Medicine and encourage pharmacists to essentially have collaborative agreements with physicians if they intend to treat their patients with for flu, strep, UTI, and a number of other things. So those are really, we're tracking over 400 bills here at the Medical Society of Virginia. As far as the scope ones, those are definitely the most high profile. But I'm happy to, Dr. Peebles, if you have any questions. I know that was a lot. It's a lot to take in. Like I said to Pia, I've been, saying this stuff in my sleep at this point. So, but happy to answer any questions you might have.
Well, no, I appreciate that. Thank you so much. I mean, we are very thankful for all the work that you guys are doing down there and leading by example. And it certainly helps us out too, as it's a regional battle as much as it is a local and state one. I did want to get your opinion on a few things.
Sure.
One, you had mentioned the bill that was heading to your Senate regarding that 2 year of experience requirement as opposed to 5 for the MPs. And I was interested, what is your overall approach when talking about these issues with lawmakers? What have you found to be compelling? What works? What doesn't? And kind of the same for the other side. What are the MP lobbies and other allied health professional lobbies doing that seems to be so compelling?
Yeah, I will say this is a little bit of a unique case, being that the sponsor is herself a nurse practitioner. And so she obviously carries a lot of weight with her colleagues. They trust her on a lot of healthcare issues. She is, I believe, the only prescriber on the Health, Welfare, and Institutions Committee in the House. So she does have her word carries a lot of weight with her colleagues. What I will say though is, we've really been making a point to, and this has resonated with a lot of folks, to really kind of pump the brakes on making a permanent change in code when we haven't collected a single data point about the effects of these allied health providers, these nurse practitioners who only have 2 years of clinical experience. Frankly, we don't even, we don't know how many there are. We know how many have 5 years of experience, but we don't know how many are practicing under this emergency order. And our Department of Health Professions, when they did this report, it was even before the nurse practitioners with 2 years could even be licensed. So none of the nurse practitioners included in that report had been practicing under that kind of 2-year umbrella. And so we're really urging caution in making a permanent change to the healthcare landscape in Virginia when we really haven't done the due diligence as far as collecting the data and analyzing it. What I will say is a difficult argument to make, and some of our allies might find, is that legislators will often, say, well, I haven't heard any, complaints. They've been practicing during this emergency, during this time of emergency, and we haven't heard any complaints. And what we'll say, what we've said to that is, well, one, have we looked hard enough? And two, if we haven't collected the data, then we're not going to hear the complaints. And two, really being that, what might work in a time of emergency shouldn't necessarily always be, our standard practice, right? Obviously, we're willing to make concessions to address a specific public health emergency, but that's a slippery slope, essentially, to make permanent changes based on those kind of conditions. What I'll tell you is, difficult from the advocate side is that, especially a lot of legislators that don't have a healthcare policy background or don't have a medicine background, they're frankly a little worn out by having to legislate on these issues. I mean, we hear that time and time again from legislators. Why do I don't have a background on this? One side tells me it's one way, one side tells me it's the other, and I don't have the clinical background to really feel like we should be the ones making these decisions. We have to, play under the rules that are before us, but, starting to kind of think about the idea of how, if there is a formal process for these kind of things at the state level, what that might look like. Because frankly, a lot of legislators are worn down and having to make these difficult decisions too.
Well, I think that's such an interesting point, and I'm glad you brought that up, because I've often wondered how they feel about exactly what you said, legislating on something that they may not have an extensive background on that has so much impact. And I'm wondering, at least in the Virginia experience, do you feel as if physicians still have that level of respect and authority that we used to have as an organized medicine and a group of providers, and how do you think that compares with the maybe galvanizing respect and authority that other allied health professions may have, and to that end, also, could you talk a little bit about what you're seeing in Virginia in terms of all of these different groups and their lobbying capabilities? What is their overall influence? How much power do they have? How are they leveraging, public opinion, maybe social media, in ways that we are not? And what do you think physicians can and should be doing that we're not already, in terms of building that public opinion?
I will say the white coats still carry a lot of weight in Virginia. What's been difficult, especially during the pandemic, and this is kind of the other side of that, of that coin, is that we haven't been able to, frankly, get as many white coats down to be in person as we might during a non-pandemic time, the before times, we might call them. We to be able to organize, a couple dozen white coats to come down to the General Assembly and sit in a committee room was a show of force. Frankly, obviously we want to be able to provide flexibility to our members so they can keep themselves and their families safe and keep their patients safe, and not ask them to come down to a windowless building in Richmond, Virginia, with poor ventilation, and where half the legislators make the choice not to wear a mask. We want them to consider the risk, and we want to be able to provide them with with the ability to lobby both virtually and in person, should they so choose. It's just difficult, just because we can't have that same show of force in the halls. And I recall back a few years ago when there was a bill to repeal the medical malpractice cap here in Virginia. We had hundreds of white coats out on the lawn of the Capitol, and we're ultimately able to defeat that bill. It's just a different time. We kind of got to rethink what that looks like, and frankly, the other part of it too that's just difficult is there are more allied health providers than there are us. Just by the numbers. The amount of training that goes into becoming a physician or going into a specialty. There's just more people who go through become an RN or become an NP, become an allied health professional. What I will say, it has been a big strength, and something that we've leaned on a lot is really the advocacy of our medical students as well. Legislators love meeting with medical students. They love their perspective. And frankly, what the medical students are able to, the kind of message that they're able to carry to these legislators, especially on these scope issues, is kind of talking about the real-time devaluing of the education that they're receiving, right? We know that medical school is different than schools for allied health professionals. There's different standards. All the stuff that you talked about, the residency, the clinical hours, all the stuff that makes a physician, makes a medical school graduate and somebody who's gone through residency different than our allied health partners. And I honestly feel like the medical students are some of the best arbiters of that message. And so we've really been leaning on them a lot. They're also, just in terms of demographics, they're across a broad spectrum of demographics as well. While we have a lot of really great members who we can bring down to the General Assembly on a pretty regular basis, it's all they want to see new faces. The legislators and especially like I said, the medical students are really great arbiters of this message. So it comes down to a numbers game. It comes down to being able to be in person. The respect is still there. It really just again becomes, okay, well, the physicians are telling me this, but the nurse practitioners are telling me this. And, from the side of, the Board of Medicine or the Department of Health Professions, or the Board of Nursing, they like to stay apolitical. And so they don't really like to weigh in. And especially when an administration changes like we've had here in Virginia. We just elected a Republican governor. And so we've gone from a Democrat to a Republican. Around this time, it's difficult for the heads of those bureaucratic institutions to weigh in because they haven't gotten the kind of marching orders from the administration of what bills they can take positions on. And so they're largely hands off. And so then it really rests on the health professionals to really come in and speak for ourselves. So it's just a number of difficulties, but I've laid out some of the strengths and weaknesses, I think, on either side.
And thank you so much. This is really great insight. You had mentioned that conflict of those two groups of voices, physicians and nurse practitioners, as an example. And I love the study of that November study of last year that looked at the rural access issue.
Yeah.
And I'm wondering, so how do you think that resonated with lawmakers in Virginia when you have nurse practitioners saying, hey, let us practice autonomously, we can provide this unmet need. And then we have this data that says, well, wait a minute, that's not what's actually happening. Do you know specifically how that played out?
Yeah, let me tell you the difficulty of that, and that was in the structure of the study, because essentially what the study allowed for was the study was under our Department of Health Professions, but it allowed the Board of Medicine to make recommendations, and it allowed the Board of Nursing to make recommendations. And so what you saw was the Board of Medicine said, we recommend that the clinical experience level stay at 5 years. We recommend, if any further advances in scope want to be investigated, that we actually collect data on those folks who have that level of experience before making any permanent changes. But then the Board of Nursing was also able to make recommendations, and they said, okay, well, let's reduce it permanently to 2 years. They also had a recommendation that said, well, let's get rid of the clinical requirement at all. Let's have come right out of school. I mean, some of the recommendations were contradictory of each other. Some of them said, well, let's cut the Board of Medicine out entirely and join the Nurse Practitioner Compact. But what made that study difficult was, while the data did tell one story, each side had kind of pieces of that report that they could pick out and use in their argument. And it's the same report, right? So the report was not black and white, but each side kind of had data points that they could use in their arguments, because the nurses would say, well, the Board of Nursing recommended this, and the doctors would say, well, the Board of Medicine recommended this. And then we would say, well, if you look at this map of the data, it shows that, it shows all these counties without autonomously practicing nurse practitioners, and it shows them largely staying in those areas where the hospitals are. But then, the nurse practitioners could, look at the same map, but look at it maybe allocated by population density. And maybe that map looks a little bit better for them, even though there's still those 29 counties. Zero is still zero. If there's not a nurse practitioner there, it doesn't matter how you break it down by population or by sheer number, just the volume of autonomously practicing nurse practitioners there. There were different maps essentially, that could be used essentially for both sides of that argument. So the report was a good tool, but it was a good tool for both sides. And so frankly, obviously with the sponsor being a nurse practitioner herself, handing her colleagues the pieces of the report that advantaged the nurse practitioner side of that argument, that's difficult to overcome when you're coming as an outside advocate, as opposed to the sponsor of the bill, who's able to directly talk to the colleagues, both of their party and across the aisle.
And how many physicians do you have in your legislature?
We have one.
One. Okay.
We have one physician in the Senate. And so that's kind of part of, what we're hoping as this bill moves from the House to the Senate. We want to set up, we get some meetings on the books with that particular senator, and lay out the limitations of that report. What the data do say, but also the limitations of, like we talked about, what it didn't look at is just as important as what it did look at. And so for her to be able to to enunciate some of those points to her colleagues as well. So yes, we only have one physician currently, but that is definitely something from a membership perspective, the MSV, that we very much are wanting to make a priority in the future. We have a Physician Leadership Institute that we hope to, it's kind of like to help new members and members who want to become more actively engaged in advocacy. It's kind of a leadership pipeline for them. And then, hoping, down the road that might lead to some of them deciding they want to run for office. And so hopefully increase those numbers in the legislature. But running for office isn't easy either.
Right, sure. Especially these days, it's worse and worse. I loved also what you said about the power of medical students, and similarly, yeah. I found that it seems to be, of course, that patient advocates are an invaluable tool as well. And I'm wondering where are the voices of the patient advocacy groups landing in these fights in Virginia? Where are they giving their support? What's your sense from them?
As far from the patient advocacy side, I mean, we definitely would encourage, we're trying to kind of promulgate some more engagement there. I think especially in terms of essentially what we're talking about when we're talking about allied health providers providing, being able to practice autonomously or, expanding their scope. We're talking about, and what we've been trying to make the point is, essentially, are we stratifying different levels of care? And are we saying that, areas that are currently underserved in terms of health provider shortage areas, should they, have less quality care, at the expense of expanding scope? It's a difficult argument to make. And, frankly, what's difficult from a patient perspective too, and I was, talking to some of my teammates about this, is that, the fact that, I wear glasses. I've gone to an optometrist dozens of times. I don't know if I've ever gone to an ophthalmologist, again, from that numbers perspective, patients often deal, a lot of times, they're dealing with our allied health partners. And if they go to the doctor's office and they see a nurse, they see a nurse practitioner, it's not always like that nurse practitioner, saying like, I'm not the doctor, I'm the nurse practitioner. From a patient perspective, distinguishing between all of the different, and then when you break down the different types of nurses, whether an LPN or an RN or a CNS or a CNP or an NP, it's just difficult for them to navigate as well. And so while we would like to see more engagement there, we've really been, as the medical professionals, the MSVs, kind of been the tip of the spear. Though I will say also, I want to give credit to all of our specialty societies as well. We work with all of our specialty societies here in Virginia, and we actually have during the General Assembly, we have a weekly lunch with all of the government affairs folks that represent each of the specialty societies. We kind of all get together on a weekly basis and say, okay, where are we at? Where are the bills that you guys care about? The bills that we all care about? Some bills are ER specific. And so, while they're obviously on the MSV's radar, they're on, the emergency physician's radar, much more so. And just kind of, being able to strategize as a group is something has proven very effective to us, to see the whole field when you have thousands of bills being proposed at one time. Like I said, MSV, I believe, is tracking somewhere between 350 and 400 bills this year.
Yeah, and I think that's just such a great point about collaborative efforts with the specialty.
Absolutely.
Absolutely. Yeah. And because I think it comes down to two issues. One, you have, as you mentioned, the truth and advertising piece and the transparency about who you're getting care from and who you're not. And I think there's a lot to unpack there in terms of, patient transparency on that side of things. And then on the other hand, you also have this reality that we have no way of really reporting when things go wrong, or we don't really have a way of knowing when a scope practice has actually led to a poor outcome. As you mentioned, even with like some of the, there's been no malpractice suit, so clearly it's going okay. Yeah, it's not that simple. And
also, malpractice suits don't move that quickly.
Right. And I think, that, and there's, things don't have to rise to a malpractice suit before they can cause harm. And so right. And I think that, I wish that there was a more coordinated way of kind of keeping track of all of this as well, because I think that it's just going to have to be data driven. And I don't know how we do that on a massive and broader scale. But I think those are really, this truth and advertising piece and knowing who your providers are. And I know that AMA and a lot of state societies, including yours, have led the charge on kind of being more or encouraging more transparency on that. But, I think it is something that we need to do more of. How do you think that state medical societies can do more collaboration with each other? And do you think enough of that is happening already? I know that with so much going on that's state specific, it kind of dilutes how much collaboration can be done. Is that something that you think of as the AMA is taking that on, or what do you think would be the role of the medical society in terms of interstate collaboration?
Yeah, that's a really great question. It's something that I've leaned on very recently, and I want to give full credit to the AMA and specifically the folks that are organizing stuff around the scope of practice partnership. Kimberly Horvath, I think a senior legislative attorney over there at the AMA. I emailed her after the NP bill got out of the House, because we thought to ourselves, how can we get the AMA and national organizations fired up on this? We need a little bit more gunpowder when this goes over to the Senate. When we talk to our physician colleague in the Senate, I emailed the AMA and emailed Kim, and I said, hey, we've got this letter that we're going to hand out to the senators on the Education and Health Committee and the subcommittee. We want to have a show of force. Can you distribute this to the national specialty societies? We'll distribute it within Virginia to our specific specialty societies. And Kim, to her credit, got that turned around in a week. We got 14 national, including the AMA, 14 national specialty or medical societies, and then we got 16 here in Virginia. So we've got a nice letter with 30 logos on it, all just saying that this bill, this is for the nurse practitioner 5 years to 2 years bill. This is not a panacea for increased access. And again, talking about what's not in that report. That's kind of being leaned on as supposed evidence for the scope expansion. And so I do think that the toolbox is there, but I do think there has to be it should be the role of the state medical societies to utilize those tools. The AMA, to their credit, is really developing that toolbox, but we need to use it. And I'm proof positive that that kind of engagement works, and because of that kind of quick turnaround that we were able to get on that letter. And I'm hoping, having that in our legislative toolbox for the coming weeks will be helpful. I can say that when we did a similar letter a couple of years ago on the issue of medical malpractice and getting rid of the medical malpractice cap here in Virginia. Just having that coalition really resonated with a lot of members, and just say, hey, it's not just the MSV, because frankly, we're having as many scope battles as I've kind of illustrated to you that we're fighting. We're, legislators were like, well, you guys are always just opposing scope stuff, and it's like, yeah, but we're not putting in the bills to expand scope, you know what I mean? And so just to say hey, it's not just the MSV, here's 30 organizations that stand beside us. So I'll say the toolbox is there, but I definitely think, that it should be the role of the state societies to engage with that toolbox.
Yep, I agree. And I just wanted to say too, Kim's wonderful, and we're excited to have her be a part of our second series and second installment of this series too.
Oh, awesome.
Yeah. I wanted to ask. You
can tell her I shouted her out.
Oh, we sure will. Have you seen a lot of efforts towards some of these independent regulatory boards in Virginia? Like, for instance, with the PAs in some states, I think about a handful of states, they have independent boards, not the Board of Medicine in the state. Have you seen anything like that going on in there, kind of, ruminating?
No, not recently. We do have a bunch of boards here in Virginia. We've got a board of nursing, a board of optometry. There are a number of boards that fall under the Department of Health Professions. What I will say is MSD is very unique among state medical societies. For those that don't know, we do have physician assistants as members of our society. We work very closely with physician assistants as members of our society, and actually, we value that relationship with them in that we are able to kind of help them on scope issues, as long as it kind of fits into our policy of that physician-led care team. Like, for example, there was the PAs, obviously VAPA, the Virginia Association of PAs. They wanted some more increased responsibility as it relates to medical examiners' offices, right? They wanted to be able to, there was a shortage of recruiting and medical examiners. They wanted to be able to practice, but it was still obviously under that auspices of it's still under the, that physician-led patient care team. And so we work with them to help get them gain that additional authority to address that recruitment issue here in Virginia. So I will say we still, we work very closely with PAs and we value that relationship, but I will say we do have no shortage of specialty boards here in Virginia under the Department of Health Professions. I can remember last year when there was a bill about, once the vaccine, it was clear the vaccine was going to start rolling out for COVID. Obviously, the legislature wanted to move so that as many people as could provide that vaccine, they wanted them to be able to provide that vaccine. And so there was a bill essentially saying that any profession that is regulated by that Department of Health Professions that's trained in the administration of vaccines could provide the COVID vaccine. And, we were able to talk to the legislator on that particular issue and say, respectfully, funeral directors are one of the folks that are regulated by that board. Maybe, we should, just maybe not everyone under that umbrella.
Right.
All due respect to funeral directors, you do provide a very valuable service. But I bet even they would say, I don't want to be giving the COVID vaccine, not to speak on their behalf. But yeah, essentially, there was a specific case regarding that. So check that out.
And have the PA groups in Virginia embraced the name change from assistant to associate, or how has that played out?
Honestly, we haven't seen any advocacy on the part of the Virginia PAs. I'm not, you referred to the vote count. The temperature I'm feeling on the ground is that wasn't, the feeling was not unanimous within the body.
Yes.
So I think you're seeing pockets, across the country of folks that are like, are we confusing, further confusing folks who were advocating for this change, making that change. I just think that that consensus maybe, wasn't super strong. And so what we're seeing is that, a lot of state organizations aren't, some are leaning into it hard, others aren't. I don't get the sense that Virginia's have been leaning into it particularly hard.
I agree. I thought that lack of consensus in that vote was one of the most striking things. I wanted to, I want to be conscious and respectful of your time. This has been wonderful. I did want to ask you briefly about the optometry issue that you had mentioned, because that is something we should be watching here in the district.
Absolutely.
But in terms of, you mentioned that optometry advocacy group came in very strong on this about doing that handful of surgeries. Do you have a sense of why they were advocating or are advocating so hard for that? Why those procedures, why now, what's kind of the motivation for that at this point?
Well, one thing I'll say is that not only did they work the issue, I mean, they hired a lot of lobbyists, and they hired them early. And some of the legislators we talked to, who we had elections in the House of Delegates this past November, and so we had a lot of new delegates in the House of Delegates who were freshmen, and we talked to a number of freshmen who said, one of the first calls I got after winning the election that night was, congratulations. Hey, by the way, we're the optometrists, and we've got a bill idea for you, or we've got a bill we want you to support. I mean, they were organized, they were mobilized, and they were working the issue, basically like right after the previous session had ended. They hired a number of high profile lobbyists here in Virginia, and they were very organized. So that's just something to keep in mind. As far as why, why these procedures, I don't have a ton of insight into that. What I can say is it's just the ones that have been been adopted by these other 7 states. I guess we'll now be 8 with Virginia, and to be able to point to those and again to say, we haven't seen a significant number of complaints. Again, they make it, they talk about it being an access issue. People have, not everybody can see an ophthalmologist, but everybody, a lot of people have access to an optometrist. It's a lot of the same arguments, just, for different issues. So, yeah, I mean, it came down to just that broad mobilization and early, and yeah, I mean, it just had a lot of momentum by the time the bill was introduced. I'll say, in Virginia, every session there seems to be just like one bill that like you would never expect that gets the most airtime. Last year there was a bill about the definition of milk, because the dairy farmers were up in arms about almond milk being called milk when it's not milk. That was the bill 2 years ago, or a couple of years ago. It was about hunting dogs. A lot of legislators said to us this year it was the laser bill, the laser eye surgery bill. It just got a lot of conversation. It generated the most emails. Like I said, it was just it was a very organized effort, and so just something that to keep an eye out for, as it is just it just seems to have a lot of momentum.
I always find it so striking whenever I have these conversations that the takeaways are always that there is no such thing as being too organized and too proactive. I mean, it's just important to have all boots on the ground for this, and we can't, as physicians, we can't just rest on this notion that we have some inherent respect, and in many ways we do. It's been hard earned, but we also have to be organized. We have to have the loudest voice in the room. We have to be armed with our data. And so I'm just so appreciative of the fact that, you guys have been doing so much incredible work, and you're so organized and so collaborative. And I think that's wonderful. And it was especially heartwarming to me to hear about, all that you do to empower your medical students. I think that's incredible too. But yes, this has been absolutely wonderful. And I hope that there's just more collaboration to come. And if you have any kind of final closing thoughts for us, happy to hear them.
I'll really just say, just to your members, what we constantly say to our members, obviously everything that everybody's been able to do during COVID, we're still not out of the woods yet. We see, our members, your members, I'm sure, just like, putting in those long hours and with no end in sight. So just eternally grateful to that. But I think it even goes to show even more that that our members and your members can do all of that, put all of that on their backs during this pandemic, and then also, show up on a Zoom, even if it's just showing up on a Zoom to talk to a legislator, like, talk about going the extra mile. So, I just eternally grateful to our members and all of the advocacy that they've been able to do during this General Assembly session, aside from managing, the effects of a global pandemic that is still very much ongoing. So thank you to you guys, and thank you to your members as well.
Well, thank you so much, Scott. And I really hope that this motivates and excites all our physicians and members in the district to be more involved with advocacy and to speak up to our council members and to make their voices heard. So thank you so very much. I appreciate it.
Absolutely. Thank you so much, Doctor.
Of course.